Hey, good evening, everyone, and welcome to tonight's meeting where Dr. Temmers will be talking to us about microscopic, ischemic, and divergent colitis and other colopathies. Shaun is a senior fellow at Kosi Albert Lutuli. And yeah, so we'd also like to thank the ECHO of New Mexico for hosting this meeting. And thanks to the ECHO India team for the IT support. If you would like to refresh yourself uh, on this presentation, the recording will be available on the Gastro Foundation website. So, Shaun, over to you.
Thank you, Dr. Seabi. Can you see my slides?
Yes, we can see them.
Okay, and you can hear me clearly.
Yes.
Okay, good evening, everyone. Thank you for joining us this evening. Thank you for the introduction. Tonight, I'm going to cover a quite diverse topic spectrum of microscopic colitis, colonic ischemia, and divergent colitis, which I've termed the other colopathies. It's quite a large number of things to get through, so bear with me, and hopefully I don't bore you to sleep. So because of the diverse nature of the topic, we'll cover microscopic colitis first, then delve into diversion colitis, and we'll close off with colonic ischemia. And we're going to be talking about acute colonic ischemia and not chronic mesenteric ischemia, which is a different entity on its own, which you can revise yourself on. So it's always important to know the definition of a disease to help better define it and understand it. So what is microscopic colitis? It's a type of inflammatory bowel disease, and it involves chronic inflammation on a much smaller scale than typical Crohn's or ulcerative colitis. It's therefore typically reported as not being visible to the naked eye on endoscopy, and therefore histology has made it quite essential. It's subdivided into three essential types, of which colitis has excess collagen but very little lymphocytes. Lymphocytic colitis, where there's lots of lymphocytes but not as much collagen, and then known as incomplete microscopic colitis, where there's a lot of collagen, a lot of lymphocytes, but just not enough to fulfill the criteria of either of the above. So it was thought to be a rare disease previously, and this is a pooled incidence in a US population study of about 11.4% per 100,000. The frequency, however, has increased by 12.8% per annum over the last 2 decades, and there's a higher frequency seen in elderly individuals, and elderly was defined as any individual older than the age of 60. And we can see in colonic cholanginous colitis that the mean age was about 64.5 years, and lymphocytic colitis, the mean age was about 62.2 years. However, in the last decade, about 1 in 4 patients that have been diagnosed with this disease have been younger than 45 years. And in the last 5 years, there's been more case reports of microscopic colitis occurring in a children and pediatric population. So microscopic colitis should always be considered in any individual with chronic watery diarrhea, specifically if they have the Bristol 7 type stool on the Bristol stool scale. Certain risk factors have been identified in microscopic colitis or exposure to microscopic colitis, and the ones that have been best studied in this disease is smoking, where up to 40% of all individuals with microscopic colitis were found to have smoked. This is found to be more common in patients with cholangiocarcinoma colitis as compared to lymphocytic colitis, and current smoking increased the odds ratio significantly compared to former smoking. The question has always been whether cessation of smoking would reduce the risk, but this has not been shown in both clinical trials as well as clinical practice. There seems to be a female predominance for this disease with an odds ratio around 2.5. Few drugs have been implicated as risk factors for the development of this disease. And it's important to realize here that this is not a typical drug causal effect, because here exposure in most of these studies had to be continuous for at least 4 to 12 months. And if the drug had related or caused the disease, the assumption would be that when the drug was withdrawn, the disease would revert back to normal, which is not the case. So these drugs were rather seen as a trigger, and it should be you as the clinician should be reminded of that. The drugs that have been studied or implicated the most as possible triggers then is proton pump inhibitors, non-steroidal anti-inflammatory drugs, and then your selective serotonin uptake inhibitors. Microscopic colitis, up to 2 out of 5 patients with microscopic colitis can have concomitant autoimmune disease. In saying that, no specific autoantibody has been identified since the onset of this disease. There's a strong linkage between the human haplotypes of HLA-DQ3-1 as well as DRQ2. And other associated diseases that you find within these patients are celiac disease. 1 in 5 of patients with microscopic colitis will have celiac disease. Autoimmune thyroiditis is also present, and then to a lesser extent, Sjogren's and diabetes. Interestingly enough, when compared to the other inflammatory bowel diseases, there's no clear association between autoimmune hepatitis, or the presence of autoimmune hepatitis, and microscopic colitis, which is quite frequently seen in Crohn's and ulcerative colitis. The diagnosis is made on histology, and there's very specific histological features. Now, if we look at our diagram to the right of our screen, most of the inflammation occurs in this subepithelial area at the lamina propria. And in lymphocytic colitis, there's an increase in this intraepithelial lymphocytes, and it's usually more than 20 per surface epithelial cells or millimeter squares. And there's an associated density per inflammatory infiltrate. There can be a thickened basement membrane or collagenous band that is present there, but it's usually less than 10 millimeters. Conversely, cholangitis colitis, which is the image diagram next to it, there's this marked thick collagenous band that is seen at the lamina propria. And this band is usually more than 10 millimeters in width, with some increase in the intraepithelial lymphocyte. Your incomplete version of the two is there's a presence of a collagenous band. However, that band is usually more than 5, and less than 10 millimeters. And there's increase in intraepithelial lymphocytes, doesn't exceed 20, but it's usually not less than 10 in that setting. That patient would then have incomplete. Important to realize that microscopic colitis, because of the paucity of objective clinical findings, these patients are often either misdiagnosed as inflammatory bowel disease, or they have some overlap symptoms with inflammatory bowel disease, irritable bowel syndrome, the diarrhea variant. So 44% of patients with microscopic colitis fulfill the criteria for irritable bowel syndrome, the diarrhea. And the subtype of these patients is usually lymphocytic colitis more so than cholangitis, whereas 9% of patients with irritable bowel syndrome diarrhea has microscopic colitis. Now, we can distinguish clinically from history between the two. And the most important thing to look at in this table, which is trying to illustrate here, is the stool consistency and the stool frequency. So stool consistency in a patient with irritable bowel syndrome is usually soft, it's variable or hard. But in microscopic colitis, the hallmark of disease, it's watery, soft stool. The frequency, it's usually high, and it's a more consistent frequency that you have, whereas with patients with irritable bowel syndrome, IBS, have a stool variability of consistency during the course of the day. And the presence of an autoimmune disease in a patient that has been diagnosed with IBS should alert you to look for microscopic colitis in that patient. Now, looking for endpoints with treatment targets, it's always important to decide what can be clinical remission. So Watswang and his colleagues looked at this to try and look at targets for clinical remission once therapy is induced. And chronic diarrhea itself was defined as more than 3 defecations per day, persistently for more than 4 weeks. Microscopic colitis is defined with watery diarrhea, as mentioned before, the Bristol stool type number 7. And in the case series that was done, or the cohort of the patients that was done, consistency was thought to be a better marker of activity. From their work, they developed this criteria looking at clinical remission and disease activity. And the criteria and disease activity were based on both stools, but if you pay attention to the left of the table over here, even the presence of a single watery stool per day, even though it was less than 3 stools formed per day, that would still define active disease. And that's important in following up these patients. What about a colonoscopy? Where's its role? It's often reported as being normal, and it's normal in the sense that you can find some non-specific findings. It might be some erythema, which is commonly reported, and the odd erosions, but typical cobblestoning or ulcers as seen in patients with ulcerative colitis or Crohn's disease are not typically seen in these patients. Colonoscopy is essential to assist with diagnosis, and here the biopsy should be taken from both the right and the left colon. Ideally, the endoscopist should mark these specimens separately, thus not to confuse the pathologist, as the collagen band does increase as you move further anally. So in other words, the left side of the colon does have a bit of a thickened basal laminar membrane. Budesonide has been shown as the only therapy in these patients that has shown some form of clinical improvement for patients that suffer from microscopic colitis. There's an 81% clinical response when used at a dose of 9 milligrams per day for between 6 and 8 weeks. It shows significant histological response at around 78%, relative risk being about 2.68. More importantly, so there was significant improvement in the gastrointestinal quality of life index in these patients. And the results of efficacy were quite similar for whether the subtype was lymphocytic or cholangionous. Maintenance therapy in patients with a reduced dose at 6 milligrams showed that at both 52 weeks and 2-year follow-up, that maintenance was maintained at around 68% of patients that had a persistent clinical response in therapy, with clinical maintenance response being seen as early as 6 months in studies that were conducted. So budesonide, being a synthetic steroid, is 95% metabolized by first-pass effects. In other words, it can metabolize within the liver itself. So there's no systemic absorption, and it's better tolerable for these patients. The issue with it, though, is cost. It's quite expensive. A 28-day course of the 3 milligram tablet works out to about 1,450 Rand a day. So for a patient to fork out the cost of a 3-month course of the induction dose can be quite expensive, and is generally not available within state institutions. Other adjuncts have been tried and has either augmented the effect of budesonide, and the 2 agents that have been shown to sort of augment this effect or help improve clinical remission in these patients of bile acid binders. And whether it was due to the fact that bile aciduria coexists with microscopic colitis, or whether the bile acids itself contributed to the development of disease wasn't quite clear within that studies. However, clinical remission was seen in patients where cholestyramine was added as an adjunct. Loperamide, on the other hand, its effects was extrapolated from data on chronic diarrhea, and it actually has a recommendation in patients with mild disease. Several cohorts of loperamide as an adjunct has shown significant improvement in the patient's symptom-reported outcomes when it comes to treatment of microscopic colitis. Now, nutrition and food is an important aspect to look at, because many recommendations are found both on the internet and from dietitian websites regarding foods and so-called elimination of pro-inflammatory based foods. It must be noted that all this information comes from observational studies in patients with inflammatory bowel disease. but no clear studies directed at patients with who have microscopic colitis. A gluten-free diet can be trialed in these patients, provided that there's a due diagnosis of celiac disease. The only diet that has been trialed in patients with microscopic colitis, in those patients that were non-responders and where there was what was deemed a favorable outcome, is a so-called BRAT diet. It contains banana, rice, applesauce, and toast. In those patients, at 3 months of adherence to this diet, there was some improvement in their clinical symptoms. Again, it was a small case series. Probiotics have shown some improvements, but currently has no recommendation. And then probiotics that was trialed there was Bifidobacterium annualis and Lactobacillus acidophilus. Boswellia serrata extract has been trialed as an adjunct as well, but again, mixed results with some patients showing improvement, others showing no benefit when compared to placebo. So there's not enough evidence yet for recommendation on these other therapies. What about the use of fecal calprotectin in the setting of a patient with microscopic colitis? Well, if you look at the pathophysiology of the disease, fecal calprotectin is mainly released from neutrophil cells, and that's not clearly involved within the pathogenesis of microscopic colitis. It does signal that there might be an organic component in patients with irritable bowel syndrome, but its predictive value is quite low. If you look at the study by Wood and his colleagues, which is illustrated with the data in the table to the right of the screen, they looked at the calprotectin in these patients that were diagnosed with microscopic colitis. And 50% of the patients that were included in that small cohort of studies had a calprotectin of more than 100 micrograms per liter. It's important to note that certain countries use a calprotectin level of around 80 micrograms per liter as cutoff for referral for colonoscopy. So you would end up missing a large proportion of patients if you're going to use a calprotectin in a patient with chronic watery diarrhea as a sort of marker to sort of work up your patient. So it has no role in the management of microscopic colitis and should not be used. So the UEG has proposed an algorithm, which is the algorithm on the right of the screen, for the management approach for these patients. 90% of them will have some response to budesonide. There's a similar response to prednisone. Equivalent dose of 9 milligrams is about 40, and that's again 40 milligrams of prednisone. That's extrapolated from IBD studies, but prednisone itself is not recommended as first-line therapy for these patients due to systemic side effects. In patients that do not respond to budesonide therapy, it's important that you consider adding adjuncts, whether it be loperamide only or a bile acid binder. Those patients will show some form of improvement, and they might actually end up with remission or clinical remission at that stage. But once there's been a single relapse for these patients, you should offer them maintenance therapy, and you start at 6 milligrams and then wean it down to 3 milligrams. And maintenance therapy can be continued for up to a year, but at 6 months, you should review the patient with regards to the clinical response. In other words, has the watery diarrhea resolved? In patients that have failed maintenance therapy with budesonide, you can use alternatives, but the alternatives that are available is our normal armamentarium of immunosuppressive drugs, biologics that we have available, but these were all used on single case-by-case basis with variable outcomes for these patients. Surgery has been tried for some of these patients, also with the non-favorable outcomes. So currently, if you have a patient, give them induction therapy, wait a while. If they relapse, give them induction therapy. And these patients tend to go through this sort of loop cycle on this side of the treatment algorithm for quite a long period of time. Take a bit of a breather here as we move on to the next part of our slide set. We'll move on to diversion colitis. And again, the definition here is it's inflammation of the mucosa in the defunction segment of the colon after either a colostomy or an ileostomy. It was first coined in 1981 by Gotzier in a series of about 10 patients Importantly, all those patients were asymptomatic, but around 1/3 of them will have symptoms. 87% of those patients that do have symptoms will have features suggestive of inflammatory bowel disease. Most frequent symptoms that you can find is that of pelvic anorectal pain, tenesmus, mucosal discharge, and rectal bleeding. Low abdominal discomfort has been reported. The issue, though, is there's no pathognomic features, and the incidence will reach almost 100% from the onset of from when the ostomy was created. And the first symptoms usually occur within the first 4 weeks in the diverted segment, but as late as 3 years can occur as well. Interesting part about this disease is the symptoms resolves once fecal stream is restored in 100% of cases. Now, this diagram illustrates the colonic intestinal mucosa when the fecal stream is normal. So if we look at the endoscopic image A, you can see that it's normal continuity of the fecal stream, and that's normal jejunal mucosa. Image B is the proximal segment of the diverted colon, and already there you can see that there's mucosal edema that has occurred within that segment. And the further distally you move away from the diverted segment in image C, that patient looks like he's got a severe colitis in that setting. The appearance is what matters, and macroscopically, you can have all features that are quite similar to that of ulcerative colitis or Crohn's disease, where you can see diffuse granularity, mucus plugging, edema. However, the most frequently seen features in these patients is blurring of a vascular pattern, mucosal friability, and edema. Microscopically, though, even though you might have similar features of crypt budding, crypt abscesses that might be seen, some Paneth cell metaplasia here and there, the histological feature in a diversion colitis is that of follicular hyperplasia and this sort of superficial coagulative necrosis. It can often mimic Crohn's disease, and therefore it's important to speak to the pathologist to look for sort of Crohn rosary, which is just a lymphoid aggregates on the outer border of the muscularis propria, which can be missed by pathologists that aren't aware to regularly look for these things. Why does this happen? Now, this diagram illustrates a colon where you've had a colectomy done, and now you've got a diverted distal segment. Now, this blind segment in itself has no bacteria, there's no nutrients that is coming along from the proximal stream without any bacteria. There's no nutrients for them to break down, so you can't produce further short-chain fatty acids. This leads to cell death, inflammation, and you get this sort of IBD mucosal damage. You take a closer look at that short-chain fatty acids. The short-chain fatty acids, when they are reduced, they result in increase in arteriolar resistance. This leads to a reduction in nitric oxide production. And therefore, there's a reduction in vasodilatation, and you have ischemia. All of this leading to further necrosis and cell death. So unfortunately, I cannot say this author's name, and I apologize, but he and his colleagues developed a staging system based on 145 consecutive patients that they reviewed with defunction colostomies of any cause. And they managed to group patients into 3 distinct clinical groups, which responded quite well to different therapeutic interventions. So group 1 was that of where there was no clinical, morphological, or endoscopic evidence of a colitis. And here, your management was conservative options for those patients with these symptoms. And you had an array of choice of enema slurries, and you could follow them up as needed. The other 2 groups were divided into those that had a sort of a severe form of the disease, where the image is quite comparable with an acute severe ulcerative colitis, or where there is early ulceration, swelling, and edema that you can see sort of mild and moderate group. And in and these patients that were staged into group 2, trial of tropical slurries with the aim then to restore fecal stream was adopted. And these slurries showed to be quite effective that contain short-chain fatty acids. So this table summarized the available data on short-chain fatty acids and their formulations. You can see that the formulations of most of the short-chain fatty acids, the active ingredient here is butyrate, which seems to be the short-chain fatty acid that studies the most and is implicate or deficient within the mucosa of these patients. Now, the original study by Harry used a 60 ml twice a day for 2 to 4 weeks, and it showed significant endoscopic response and microscopic resolution in that diverted segment for those patients. Subsequent studies that had sort of similar mixtures to the original study, but they were much shorter, had a bit of conflicting information. The one by Newt showed no significant changes in both the flora, and then Shoba showed that there was no difference when they compared their slurry solution to that of saline. However, the use of coconut oil, which is also high in short-chain fatty acid by Zandler, this was done continuously for 6 months, which is the longest study that was done, showed that there was clinical remission, histological improvement, and endoscopic improvement at as early as 6 to 8 weeks. And this was maintained during the course of therapy. So surgery as a whole for this condition, you put the 2 pieces of colon back together. Surgeon decides whichever way he wants to put it back together, and the disease is cured. The most important part that needs to be explained to the patient is that there are major side effects and complications that occur in these patients. They're usually patients where surgery, their abdomens might be hostile because of the prior requirement for their ostomies. So there might be bleeding, infections, anastomotic leaks is a reality. And even if there's none of those, later complications such as strictures can occur, which might require direct attention, as well as the anesthetic risks that these patients will have. So other strategies have been tried in these patients. 5-ASA enemas have been tried at 4-gram daily dose for up to 4 weeks. The issue here was that you got this sort of intolerance to 5-ASAs, as we see in some of the patients with IBD. However, this was not self-limiting, as is seen in the IBD patients. It's sort of persistent, which made 5-ASA enemas not really attractive for the patients. Fiber irrigation was tried in 11 patients where they used 5% fibers for about 7 days, and there was significant endoscopic improvement within the mucosa. And its role was considered very operatively in that setting. Dextrose spray was tried in a single patient. Endoscopic irrigation of 50% dextrose, and 2 weeks post-spray, there was completely a normal pouch with no bleeding or friability that was found in this patient. And whether the dextrose acted as a sclerosing agent was thought to be the case. With the benefits of this was it was low cost and was relatively safe. So it could also be used as a sort of perioperative management. But the real attractive solution is FMT. And this is autologous FMT, and it's used 3 times a day for up to 4 weeks within patients. All the symptoms dramatically improve as early as 5 days. And when colonoscopy was done 28 days later, there was no inflammation within the stomach. The benefit of this method is that no real screening of the stool that's required, because using the stool that's coming from the same patient, the stoma, all that's required is to turn it into a slurry, filter it, and apply the FMT. So that seems to be the most attractive option, especially in patients where even though surgery is indicated, but not a viable option. So again, the UEG proposed a treatment algorithm for these patients that present with symptoms and clinical features suggestive of a diversion colitis. And the important part to take from this algorithm is that once you have these patients, you should apply a grading or score system and score the extent of the disease so that you can sort of risk stratify these patients. So if possible, you should score them according to Harrick's scoring system, whether the disease is absent, mild, or severe. Once you've done that, patient stratification should be done. Does this patient fulfill features that make them a sort of low risk diversion colitis, moderate, or severe diversion colitis? You should consider other etiologies in these patients prior to labeling them as a diversion colitis. Where possible, reanastomosis should be pursued because the pathology reverses. However, you need to find a keen surgeon that is willing to assist you in the care for these patients. Where diversion is not possible, your patients should then further be risk stratified because that diverted segment carries an independent risk for the development of colorectal cancer. And if the individual itself has a low risk for colorectal cancer, then screening can be delayed up to 3 years. But if there's a high risk patient, then you should provide screening in that diverted segment at least every 12 months due to the colorectal cancer that the diverted segment carries. Take a bit of a breather. And we move on to the last segment. So the preferred term is colonic ischemia, as there's no true colitis in these patients. The physiology here is due to reduction in intestinal blood flow, and it can either be due to small vessel occlusion or hypoperfusion. There's injury to the colonic mucosa. This results in some degree of transmural ischemia, whether it's patchy or complete. Its annual incidence rate is increasing. It's 17.7 per 100,000 in the US and around 16.4 in European cohorts. It increases with age. So once you're older than 49 years of age, your risk for developing colonic ischemia increases by 0.87% per annum if you have significant risk factors. Significant female predominance to men. 3 out of 4 patients, all reported cases were female. It carries a significant mortality risk, up to 12% in patients. In patients with an isolated right-sided colitis, the mortality risk is even higher. Clinical features that they present with, by far the commonest is that of abdominal pain. It can be pain anywhere within the abdomen. Rectal bleeding is reported, especially if the disease is limited to the left side, and then diarrhea can ensue in these patients. If we go back to the anatomy of the colon, we look around at the so-called watershed areas of the colon. Important landmarks to remember is that of Griffith's Point, which is the anastomotic site of the inferior mesenteric artery and superior mesenteric artery around the splenic flexure. Sudeck's Point is where the inferior rectal artery and the superior colonic artery joint, and that's the watershed area. And then the marginal artery of Drummond supplies predominantly the right side of the colon. About 50% of individuals have an underdeveloped marginal artery of Drummond on the right-hand side. And this anastomotic point between the marginal artery of Drummond and the ileocolonic artery is another watershed area to consider. Sorry. So the risk factors for developing colonic ischemia includes any patients that have comorbid cardiovascular disease and diabetes mellitus. The presence of irritable bowel syndrome, especially constipation phenotype, the presence of chronic kidney disease, a history of thrombophilia, or in this was the first event if thrombophilia should be excluded. Abdominal surgery, specifically abdominal surgery on the abdominal aorta within the last 3 or 6 months. And then there's a whole list of drugs and medication that have been implicated, about 3 or 4 tables of them. Importantly is immunomodulators and chemotherapeutic drugs because of the vasoconstrictive effects on the mesentery have been implicated. Constipation inducing drugs because of pressure effects that they exert within the colonic mucosa. And then illicit drugs have also been implicated, specifically again for the vasoconstrictive effects such as cocaine. So these are the important class of drugs that you should look for, but there's a whole list of drugs that can cause this, which is available on the AJ's website. Now, when patients present with colonic ischemia, they often present with either abdominal pain or they have diarrhea. They don't always have rectal bleeding. There are certain features in those patients that you would not consider conservative management for, and you would opt for closer monitoring and early surgical intervention or plan for early surgical intervention. These include male gender, whether the patient has renal dysfunction or not, or if there's a clinical history of atrial fibrillation. If there's features of peritoneal signs in these patients, if there's no significant rectal bleeding, but the pain is disproportionate to the rest of the clinical symptoms, then that patient will fail conservative therapy. And then other features such as evidence of pre-peritoneal air on cross-section or imaging, or if the disease is localized to the right side of the colon. The laboratory test that or worrisome is if there's already evidence of inflammation or septicemia has set in, those patients carry a worse prognosis. The serum lactate here is more of a marker of hypoperfusion than anything else, but it does give us an idea of the severity or the likely mortality that these patients might have. So there's a ischemic colitis mortality risk score that can be applied to patients. And this is a risk score that has 5 parameters to look at. It's a numerical score. You look for the presence of these risk factors, which include a preoperative lactate of more than 2.5, if there's acute kidney injury, if there was the use of, if the patient went to theater, that to use catecholamines or not, if the patient has a pre-existing low output cardiac failure, or the type of surgery that was done at when surgery was required. If you look at the scale, though, for every additional risk factor that the individual has within the score, your mortality increases. So you have all 5 risk factors, you have 100% mortality. But even in the absence of any of these risk factors, you still have about 11% mortality risk without anyone doing anything. A table at the bottom there is just additional factors that could influence severity in the patient. That's not included in the ICMR. There are specific indications for surgery to be aware of. And in the acute setting, if it's peritoneal signs, massive bleeding, patient has toxic melanoma or pulmonary colitis, there's gas within the portal venous system, there's nematosis intestinalis, or the patient's clinical condition is persistently deteriorating over a 48 to 72 hour period, that patient needs urgent surgical intervention. So a subacute indication is in a patient where there's a segmental colitis that initially responds to therapy, but then now is responding to achieve this maintenance of therapy. They're having this ongoing protein loss from their colon, and they're just having recurrent sepsis. That patient is probably a candidate for surgery. And then chronic indications is if there's transmural injury, it heals via stricturing, and the stricturing is not amenable to endoscopic therapy, surgery is required for that. In saying that, the ischemia itself has different phases. So If you look at the blue sections of this diagram, ischemia can either be transient, partial thickness, or it can be a full thickness infarction. If you look at the transient ischemia, here the ischemia is limited to the mucosa. So there's a mucosal infarction that has occurred. The changes will only be limited to the mucosa, and it will heal with a residual mucosa scar. If we look at partial thickness ischemia, here there's infarction from the mucosa to the muscularis. And this patients will heal with stricture, or there will be luminal narrowing, or the normal anatomy will be lost in that patient over time. And these are usually caused by hypoperfusion or an embolic or occlusive disease. And it's usually your segmental type of colitis that you see. Whereas a full thickness infarction is transmural and there's tissue loss. And this is usually due to large embolic infarction of the SMA itself, or long segments, especially involving the watershed areas, as alluded to earlier. When the patient presents with the abdominal pain, the CT is your diagnostic modality of choice, and it should be a CT topography with both IV and oral contrast. And the CT can help you distinguish between those three types of ischemia, two categories of disease. You can see that there's sharp cutoffs within the CTs, as illustrated by the sagittal and coronal images on the slide. And the difference between this and what we would see normally in colitis is that there's usually no perifat stranding or hyperemia that is seen in patients that have an active colitis. Endoscopically, the role there is to go and have a look, but a gentle look. And here, when you do a colonoscopy in these patients, ideally you shouldn't use air insufflation. CO2 insufflation is preferable in these patients, or underwater submersion techniques. So a classical feature is a so-called single stripe sign, which is this longitudinal stripe of ulceration or inflamed segment of the colon. Once you've reached that, you don't have to transverse it. You can sort of view it, see what the distal end of it is, and then you can sort of make your way out of the colon. Other things could be simply just erythema, mucosal bleeding with some intraluminal blood. Once you see ulcerations, erosions, and intraluminal clots, you should not proceed any further with the colonoscopy, as the risk of perforation through that disease segment is quite high. Again, the AGA proposed a management algorithm for these patients. It's quite busy, but the important part is that disease can either be mild, moderate, or severe. And you, as the clinician that's assessing these patients, need to decide where this patient fits into. If it's mild or moderate, that patient requires supportive therapy, where you then correct the cardiovascular abnormalities, replace the volume. Broad-spectrum antibiotics are trial. There's no evidence for their use, but they are still used, and you sort of stabilize those patients. In your patients with severe disease, there is identifying early imaging of the anatomy and early surgical intervention where possible. Often these patients are quite severely ill, where surgery might not be an option for these patients. So I'm going to conclude with this summary slide of these three quite distinct diseases that I've talked about this evening. The first was that of microscopic colitis. It's not rare, it's inflammatory, it's subtype of inflammatory bowel disease, and its distinguishing feature is persistent watery diarrhea, and that defines quality of life. And the aim of therapy is to reduce the watery diarrhea. Topical budesonide has been shown to be highly effective for this, and most patients are highly responsive to budesonide therapy, and they'll go through cycles of having relapses, and remissions, relapses and remissions. And for every relapse, it's always important to see what was the trigger in those patients. But steroid refractory microscopic colitis does exist, and you should be aware of it. And when you identify it, rescue options should be implemented or sought for your patients. Important to tell patients that there's no colorectal cancer risk, but adequate follow-up should still be offered for these patients. Again, just to mention on microscopic colitis, at the relapses, the diagnosis have been made of microscopic colitis, and there's no other indications suggest a different disease. There's no need to go and do a repeat colonoscopy or even biopsies in those patients for microscopic colitis. Then diversion colitis, up to 2 out of 5 patients are asymptomatic. Short-chain fatty acid slurries are effective if you're able to obtain them, and they should contain butyrate as your substrate. Surgery is often cures the problem. Problem is in these patients that do get reanastomosed, there's a bit of bloating and pain that may persist afterwards. In those patients that are not amenable for surgery, that the diverted stump carries a colorectal cancer risk, and you should offer that patient some form of screening for colorectal cancer in the residual diverted segment. Colonic ischemia is generally a disease of the elderly, but it can occur in the young. There's a high mortality if it's not recognized and treated early, of which is mostly supportive care. Conservative therapy, when implemented correctly, has excellent outcomes, and these patients will heal with some form of scar tissue that will require some form of intervention at a later point in time. Therefore, follow-up is important in these patients. And I'm going to leave you with that, and I'm going to end my talk there. Thank you for those that are listening, if you're still awake.
Well, I hope they are. Thank you so much, Shaun, for this very excellent overview. I don't think it was too long, and I mean, it was a big topic. So I think you covered it quite well. And yeah, Dr. Kokela agrees with me. I think there was just one comment from Yusuf about the collagenous colitis. Remember, collagenous, hey, Shaun? Collagenous colitis. So the unit of measurement that you used was 10 millimeter. Thanks, Yusuf, for picking that up. So it's 10 microns. Are there any questions or comments from the audience? So, I mean, so if I may just start while people think of questions, I think, with microscopic colitis, the issue that most of us will have in the academic hospital is lack of access to budesonide. Maybe colitis care is different. I don't know if you guys have in KwaZulu-Natal, but in our case, it's been discontinued for a long time. So if we do get such patients, then prednisone is what we'll use because we also don't have cholestyramine. Yeah, and I also just like the fact that you mentioned that, even though it is termed microscopic colitis, sometimes you might see some very subtle changes. But the main thing is if you suspect it, make sure that you do the biopsies on both sides of the colon. With regards to diversion colitis, I think the issue that we often have is that the let's say you've got maybe a patient who's had Crohn's disease, ileocecal resection, and they've got an end ileostomy, and now it's time to consider reversal. And we often have to look at that diverted colon segment, and firstly you have to deal with the dirt because it's difficult to clean that part of the colon. And even if you were to do an enema, it'll only reach, this far. If the person has an end ileostomy, it's just difficult to really assess the colon properly. And now you have to tell the surgeon that, okay, the patient the Crohn's is under remission, is in remission, and you can reverse the stoma, but you may find that there is this diversion colitis. But what I found commonly is those mucus deposits that you've mentioned, mucosal deposits, and it's very friable. Like you may go into the colon and you find that it's not too bad. You're just dealing with some residual stool, but then when you come out, you see these red blotches along the end. So it's a very delicate segment of bowel that you deal with, and you have to be careful not to overcall and say this patient has got severe colitis, whereas it's just that, once you start inflating your colon, then you would have brought on those changes yourself. Um, yeah, and then with ischemic colitis, often the scoops are done without prep, so underwater immersion can be difficult
Yeah.
because once you put in water, then you'll just see brown. So I usually prefer to go in with just minimal CO2 insufflation. I think there've been some. Where's the chat thing? Chat. So Yusuf would like to know if there are any pathognomic features on histopathology.
Yeah, so there isn't any really for colonic ischemia itself, because the problem is depending on the type of ischemia and the time of when it happened, you will see either some form of healing or new inflammatory infiltrates. Sometimes you might see necrotic cells. Sometimes you might see cells that are sort of changed in the mitotic phase. Because if it's only limited to the mucosa will heal quite quickly. Like those patients, they'll settle quite quickly, and then within a few days, they heal with scars. So there's no real pathognomic features that have been found in the histology for patients at biopsy, as opposed to patients that have a diversion where you can clearly have this follicular hyperplasia that has been reported in those patients, but not for colonic ischemia.
Yeah, that's right. I mean, the I don't know if it's pathognomic, but you can see hemorrhage in the lamina propria. But I think I mean, Shaun is correct in saying it depends on what stage of the ischemic colitis or colonic ischemia you biopsy. And often you find that you don't biopsy that area with the deep ulcers, because the muscularis is
Mhm.
just there. You biopsy that and you've got a perforation. So often you biopsy along the edges, and then some of the pathologists will say that maybe there is some hemorrhage in the lamina propria or hemosiderin. Um, yeah. Yonela would like to know if there's any role for biologics or immunomodulators for patients who fail to respond to budesonide. Is this for a microscopic colitis, Yonela?
Yes, it's for microscopic colitis.
Yeah, I think he had mentioned
Look,
it in that
in
diagram, Sean. Maybe pull up that diagram.
yeah. So in patients that have you're alluding to patients that are steroid refractory. There are
Mm.
studies in patients where both azathioprine has been tried for those patients. However, the patient-reported outcomes in the resolution of watery diarrhea has not been sufficient to say that it is a viable second-line option. Vedolizumab and infliximab both have been trialed on an individual patient basis, and some patients do have significant good clinical responses. But the evidence in those studies is too weak to currently recommend their use. But vedolizumab has shown that the patient that was steroid refractory, there was some improvement in them, but a very small series of patients. And whether or not it was the addition of the bile acid binders, whether that assisted, that wasn't quite alluded in that studies itself. So currently, there's no recommendation for their use, but they have been trialed, but it's very small case series that have been trialed in those patients. And look, What I didn't mention, start with microscopic colitis, there's not a lot of randomized control trials in the disease for its treatment. It's a lot of observational studies and sort of case series or case control studies for them. And most of the data has been like, there's been nothing new in the last, I think, 5 years or so for microscopic colitis. And even if you look at the guidelines, that's why it hasn't been updated in quite some time.
Okay, yeah, I think that's all the questions on here. I had just made a note here, just out of interest. Professor I.C. Seagal, some of the older people might know him. I actually know of him. I've never met him, but he was the head of gastroenterology at Bara, and he's the one who started the WGO training center. It was called the African Institute for Digestive Diseases. So, on his PhD, well, I don't know if it was part of his PhD, but he looked at, African patients in Soweto, with regards to the prevalence of colonic polyps, inflammatory bowel disease, and whatnot. And I saw one of his studies where they determined the amount of short chain fatty acids in Africans. So they actually measured the short chain fatty acids in the stools of Africans. I think he compared them with Caucasians, and I think they found a high amount of short chain fatty acids in the stool of African patients. And he then used that to say that maybe that's why ulcerative colitis and colonic polyps are not common in those Africans in Soweto. But I think that was maybe before the 90s or maybe early 90s. And as we know, things are a bit different now. We're seeing quite a lot of polyps and we're seeing inflammatory bowel disease in Africans. But yeah, I thought it was interesting. Dr. Ramanati, I've come across bile cells being implicated. Oh, well done, Shaun. Okay. I'm not sure if there's anyone else with a burning thing to say. I'll give you 5 seconds. Okay, so if not, then that leaves me to thank the presenter, Dr. Shaun Temmers. And just to remind you that the recording will be available on the Gastro Foundation website. Our next session will be on Monday, the 11th of November, so not next week. And the presenter will be Dr. Nassif van der Schijf, chaired by Professor Jill Watermeyer. Yeah, so I'd like to thank everybody for attending and wish you a good night.
Thanks. Good night.